Hello, and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Maternity Case Management Training. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You'll need to register for this program in order to access those materials. Continuing education credits have been approved for social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will only be awarded for 2 years, expiring on July 31st, 2018. If you are watching this program on demand and want to receive a social work CE certificate, then you will need to complete the social work test and send it in, along with your sign-in sheet and evaluation. If you are watching this program live, there is no social work test required. I'm Meredith Adams, Director of Social Work for the Bureau of Family Health Services at ADPH, and with me is Paige Mitchell, the Family Coaching Program Director for the Gift of Life Foundation. Welcome, and thank you so much for joining us, Paige. I'm so glad you were able to come. This is going to be great.
Thank you for having me.
I want to remind you also on the on-demand page for the program are several different attachments. The maternity protocol is there. The report to referring provider is there as well. It might be beneficial for you to print that out so you can kind of walk through the protocol and the report to referring provider with me as I'm going through the training. I'm not going to address every single question on the report to referring provider, so if you have a specific question about it, please do not hesitate to call or email us while we're on live. Or if you're watching on demand, you can call or email me anytime about questions related to that. So today we're going to try to understand the maternity case management process and understand the various educational items that will need to be explained to patients, the Gift of Life family programs, and the documentation requirements for maternity referrals. The good news is that Renee and I both have done maternity case management, so if you get going with it and you have some questions, we are more than happy to handle those and step in and try to help you as much as we can. For years and years and years, case managers have been told you cannot work with pregnant patients. So we have kind of hammered that in pretty good. So this is a big change for ADPH. So why is it that we're able to do this now? Well, as y'all are aware, change is inevitable at this point. You would think we would get used to it by now, but we haven't. So this is yet one of those other big changes that are happening through the RCO process as well. So kind of a few stars have aligned to allow us to be able to do this. The first piece that happened was the Gift of Life did not renew their maternity waiver contract, which meant there was no case management services for the pregnant women that are in Autauga, Bullock, Butler, Crenshaw, Elmore, Lowndes, Montgomery, and Pike. And these are the only counties that we are going to be doing this level of maternity case management. Medicaid has also eliminated SOBRA Medicaid. This has allowed all pregnant women who once qualified for SOBRA are now eligible for full Medicaid services during the pregnancy and through the postpartum period. The full Medicaid coverage is what is allowing ADPH to bill patient first for case management. So we're billing under patient first, and I am working on some protocol changes to get that out to you as well. Coding. We are going to be coding to service area 81. This is going to be a new service area that will be put into ACORN. 81 is going to be for patients under the age of 21. 82 is going to be for patients 21 and older. And activity type 4 for all services. So the process is going to start first with verifying the patient's Medicaid status. If the patient does not have Medicaid, then you will assist the patient with the Medicaid application and follow up with the patient to ensure that Medicaid has been obtained. You want to track how long it's taking for the patient to acquire Medicaid, which will be documented in the progress note as well as on the report to referring provider. The RCO is very interested in how long this process is taking because we're hearing from the history. I've talked to Paige about the program quite a bit, and one of the issues that the Gift of Life was seeing was it takes a while for the patient to get on Medicaid, and the doctors won't see the patient until they have that Medicaid coverage. So we want to try to assist them in getting the Medicaid as quickly as possible so they can get in for that first prenatal appointment as early as possible. Maternity case management will be performed in the health department. We are not asking you to go out to the private providers' offices. We are not asking you to go into the hospital. We know you are not going to get every single maternity patient that is on Medicaid. The way we foresee this happening is through the WIC clinic, because most of the patients will be coming in for WIC eligibility, so we're hoping you're going to be able to pick them up when they come in for their WIC. You are welcome to market to private providers and let them know that we are now offering this service as time permits. But that is not an expectation or a requirement. It's as time permits. We're also thinking that as the private providers learn that we're doing this, they're going to start sending you patients as well. All patient first referrals must have a referral form completed in ACORN. Under the Referring Provider tab, you're going to select Self-Family as your referring provider. The reason for referral, you're going to select Maternity Case Management. This is for data purposes so we can track how many of these patients we're seeing. Sometimes you will meet with a patient that does not want to continue with the pregnancy. You'll need to refer that patient to the Yellow Pages or have a referral sheet with multiple referral sources that also include abortion clinics. Never, ever, never, ever, never give a patient the name and number to an abortion clinic on a piece of paper by itself. This could be seen as coercion. If you'll pull your Plan First protocol on the very first page, it talks about the Title 10 requirements. Clients cannot be coerced to accept services or to use or not use any particular method of family planning. I'm required to inform personnel working within the family planning project they may be subject to prosecution if they coerce or try to coerce any person to undergo an abortion or sterilization procedure. So please do not give out an abortion clinic name and number without anything else on the piece of paper, because you could possibly be prosecuted for coercion under the Title 10 regulations. So just wanted to make sure you were aware of that. A psychosocial assessment is going to be required on all maternity referrals. We're going to be working with these ladies for hopefully a few months. So please complete the assessment completely. Renee has done an excellent job of pre-populating your case plan for you, and we're going to touch base on that in just a second. The perinatal program, they have a nurse that we're going to grant ACORN access to because she's going to start pulling data off of that psychosocial assessment. Your case plan is required on all maternity referrals as well. This has been pre-populated with multiple goals so that we tried to limit the amount of typing. So if there's a goal that's listed that's not going to be needed, you do not put a date in the problem identified box. Once you put a date in that problem identified box, that means that that goal is what I'm going to call, quote, active. So you'll just leave the date box empty if that need is not necessary. The goals on the case plan are to assist the patient in scheduling the first prenatal appointment, reminders for all prenatal and postpartum appointments, acquiring Medicaid, referring to WIC, assess and refer for smoking cessation, refer for diabetic education classes, educate on safe sleep, educate on Zika, arrange for postpartum appointment, ensure patient has a car seat, refer to the Gift of Life programs, and encourage reliable birth control method. Now, the Gift of Life programs are only for Montgomery County, and Paige is going to talk to us about that in a little bit more specifically in a couple minutes. But the Gift of Life programs are only for those Montgomery County patients. The patient is going to need to establish a provider, an OBGYN, somebody that's going to conduct their prenatal appointments and be there for delivery. They can also use a midwife, and there's a list of providers for the 8 Gift of Life counties on the on-demand page for this broadcast and on the document library. The list is updated and placed on the Medicaid website under Programs, Medical Services, Maternity Care, and Maternity Care Providers. So if you have questions about, hey, I thought so-and-so was a delivering provider as well, and it's not on our list, then you can go look at the Medicaid website. We kind of created our list based off of that Medicaid list. You're going to also notice some physicians that are on that list that don't actually deliver. For example, Dr. Miller is on the list, but he's not on our list on the document library that you can refer patients to. I don't think that Dr. Miller is delivering babies at the current moment. So he would not be somebody that you would want your patients to be referred to. So we've taken him off of the list that we have on the document library. The patient has the right to select any provider, and the care coordinator will need to assist with establishing the first appointment. You'll want to follow up with the provider to assess if the patient kept the initial appointment. You'll want to track the date and weeks gestation for the first appointment. So how do we do that? Well, we're going to try to get you what I'm calling a gestational wheel. And what that is, you're not going to be able to see this on the screen, but it's a wheel that spins. And what you do is you line up when the patient's last period was, and then you can track when their due date is and how many weeks gestation they are at a certain date. So we'll get some of these out to you, and if you have questions about how to use the wheel, please do not hesitate to call or email me, and I'm happy to show you how that works. Because on the report to referring provider, we are going to ask you how many weeks gestation the patient was at the first appointment. You'll want to follow up with the patient to see how the initial appointment went and if she has any questions or needs that arose during the initial appointment. When I was doing the maternity case management, it was interesting to me how many times the patients would come into my office and start asking me questions that I thought they needed to talk to the doctor about. So that might be something that you kind of fill that role with them and let them know, that is a great question, and you probably need to follow back up with your doctor about those questions. So sometimes we have to encourage our patients to speak up in their doctor's appointments if they have questions. We want to encourage the patient to keep all of her prenatal appointments. So we need to remind the patient of upcoming appointments and assist with the elimination of barriers in order for the patient to keep all of her prenatal appointments. You're also going to keep track of those prenatal appointment dates. We also, if we're not getting the patient through a WIC appointment, we need to refer the patient to WIC. So the WIC 157 form, you could put that up in your office for easy reference to WIC eligibility, which can be found on the on-demand page for this broadcast and on the document library. It was also sent statewide in an email on 4/21/16. I sent it so you could search by my name or the date. You can also order WIC brochures to have available in your office as well. Just for quick reference, the WIC Income Guidelines are listed here for you as well, and there are phone numbers for you to call for the patient to call if they have questions. So just a quick glance at what the WIC Income Guidelines are. Smoking cessation. If the patient uses tobacco, encourage them to quit. You'll want to explain the health risks that are associated with smoking during pregnancy. Smoking during pregnancy can increase the risk of a low birth weight baby. You can also explain the monetary benefits of quitting. When I worked with one of the physicians, I liked the way he tried to coax a patient into stopping smoking. What he would tell them is, take the amount of money that it costs to buy a pack of cigarettes, and you put it in a jar or put it in a drawer where you can't touch it. And then when you've officially quit, you take all of that money and you go buy something fun. Not something that you need, but something fun. It's some type of a reward that, hey, you quit. And it's amazing how much money the patient can acquire during that pregnancy period for not having to buy those cigarettes. So just trying to think outside the box and find different ways to try to encourage the patient to quit smoking anything is great to try and help them to quit smoking, especially when they're pregnant. You'll want to encourage a referral to the Quitline. The physician is going to have to complete paperwork in order for the Quitline to provide smoking cessation medication to the pregnant individual. So you'll need to assist the patient in the completion of the paperwork if she agrees to quit smoking. So where do you get the forms? You can access the forms through the ADPH homepage. I just clicked on the A to Z index. I went to Q for Quitline, or you can go to T for tobacco, and it's quitlinealabama.com. At the top, you'll select Provider Referrals, and here is what it looks like when you do that, and it gives you information on how to submit the form. There's also going to be a prior authorization that's required. That's what that physician's going to have to fill out. So you might have to help through that process depending on if the patient is willing to do that type of thing. Gestational diabetes. Gestational diabetes test is conducted around 24 or so weeks. So you'll want to encourage the patient to complete this testing. If they are positive for gestational diabetes, you'll want to refer the patient to diabetic classes conducted by a certified diabetes educator, or a CDE. For a lot of this presentation, what I did was I just did a Google search. I just typed in certain things into Google and wrote down what the links were. So I found several gestational diabetes classes at Baptist East. So the care coordinator may want to do the same, just to Google certified diabetes education classes and see what type of hits you get in your area. Educational classes are important for patients to be referred to. So you'll want to encourage a referral to childbirth classes. These can be found through Jackson and Baptist hospitals. And you'll want to encourage a referral to breastfeeding classes, which can be found through both hospitals as well. This is a main piece of what we're doing with our maternity case management, is we're going to be providing a lot of information to these patients and a lot of encouragement to try to help them with some behaviors that are better for the baby. So we want to encourage breastfeeding for the patient. You'll want to check out the ADPH website under WIC and the perinatal program for more information. You'll want to let the patient know that any amount of breastfeeding is a great start and to encourage it as much as possible. Discuss concerns with the patient about breastfeeding and offer support and encouragement. WIC offers supportive services for breastfeeding moms, and a consultant is available in the central office for breastfeeding questions and resources. Michelle Granger, she works in Family Health Services up on 13 with us, and her number's on the screen. You can also email her as well. WIC can assist with acquiring a breast pump and other needed supplies. And the breastfeeding moms, I think they get different food instruments, so they get different foods when they're breastfeeding. I think they actually get more foods when they're breastfeeding. So that might be something to help encourage them to try the breastfeeding as well. I also Googled the benefits of breastfeeding. I just typed into the Google search box, benefits of breastfeeding. I got multiple hits immediately, and there's a lot of great information out there. WebMD has a great link, Fit Pregnancy, Women's Health, Healthy Children, Baby Center, and La Leche League. So there's a lot of great information and resources out there for breastfeeding that you can look up so you can be more prepared to talk about breastfeeding. Early elective deliveries. You'll want to educate the patient on the issues that come with early elective deliveries. An early elective delivery is a delivery after 37 weeks, but before 39 weeks. That is not medically necessary. And you can Google, again, or just go straight to the ACOG website, where it gives you information about what an early elective delivery is and some of the risks to the baby. The following health problems are possible in babies who are born too early. They can have breathing problems, including respiratory distress syndrome. They have temperature problems. Babies born early may not be able to stay warm. They can have feeding difficulties. They can also have high levels of bilirubin, which is too much bilirubin can cause jaundice. This is when the infant appears yellow. In severe cases, brain damage can result if this condition is not treated. They can have hearing and vision problems. They can have learning and behavior problems. Healthcare professionals recommend that unless there is a valid health reason or labor starts on its own, delivery should not occur before at least 39 weeks. If the patient has a cesarean delivery or labor induction for a medical reason, it means that the benefits of having the baby early outweigh the potential risks. But when they are done for a non-medical reason, the risks, both to the patient and to the baby, may outweigh the benefits. When the pregnancy is normal and healthy, it should continue for at least 39 weeks, and it is preferable for labor to start on its own. The lungs, brain, and liver are among the last organs to fully develop during pregnancy. The brain develops at its fastest rate at the end of pregnancy. It grows by 1/3 just between week 35 and week 39. Also, during these last weeks, layers of fat are added underneath the baby's skin. This fat helps keep the baby warm after birth. Remember a couple slides ago I mentioned that these babies can have trouble controlling their temperature. Well, because the fat that helps keep the baby warm hasn't fully come in until around 39 or so weeks. You also are going to want to educate on safe sleep practices. So again, I've listed a web address for you here. This is through the ADPH website, through our perinatal program. And on the left side, when you get to that page, you can click on the link for Safe Sleep. You can order brochures and posters on safe sleep to have in your office and post around the health department. There are also links on the website to a video about creating a safe sleep environment. It was 3 minutes and 18 seconds. And then there was one that's also on the latest crib safety that was 1 minute and 14 seconds. I pulled them both up and watched them. So what you could do is when the patient is in your office, you could pull the videos up and review them with the patient, and you could maybe be doing your documentation or something while they're watching the video so that you know they've watched it and they've at least heard that message at least once of how to keep the baby safe for sleeping purposes. So I encourage you to watch those videos. They're super quick, but they were very informative. You'll want to remember the ABCs of safe sleep. And there is a great poster that you can order through that perinatal website. It's got a cute little baby on it, and it's got the big ABC on it. And what those mean are the A is for alone. Bed sharing can be dangerous. Babies are teeny tiny when they come. And I don't know about you, but I can be a heavy sleeper when the baby was actually sleeping. And if you roll over accidentally on the baby and you're asleep, you don't know that you've done that. And the baby can't make a sound or move or push you away. So it's very scary to think about it's in its complete accident just rolling over on the baby in the middle of the night and crushing the baby. So that's very scary. So you need to encourage the patients to keep the baby in its own safe sleep environment. They do not need to share the bed with the mama. You always put a baby on its back to sleep. So remember, it's always back to sleep, unless the pediatrician has instructed otherwise for some type of medical condition, but always back to sleep. The C is for crib. The crib should be free of all objects. This includes bumper pads. I know I had the cutest little Winnie the Pooh bumper pads up in my little man's crib, and we, of course, removed those when he came. So, you know, the crib's kind of bare once you take those bumper pads out, but you want to make sure that the baby is nice and safe. You just need a firm mattress with a tight-fitted sheet and slats that are close enough together so a soda can will not fit between them. So I know that sometimes we get hand-me-down things, and you know, the antique crib from the mom or the grandmother are great and wonderful for prettiness, but they're not really safe for the infant. So if the mom tells you, well, I've been given a hand-me-down crib, ask her to take a soda can and see if it will fit through the slats of that crib to make sure that they're close enough together so the baby can't get stuck. So we're going to transition now, and Paige Mitchell with the Gift of Life Foundation is here with us to talk to us about the various programs with the Gift of Life Foundation. So I'm going to turn it over to Paige.
Great. Thank you again for having me today, Meredith.
We're so excited.
We are too. We have received, well, as Meredith mentioned, we managed the maternity care program since 1999 in the areas that you are working. However, we have transitioned into a home visitation and a non-home visitation program. We offer family programs to our clients, the same clients that you will be serving in your program. So we're so excited to have this relationship with you and to be for you to be a referral source for us for these programs. We have had a Healthy Start grant since 2012, where we have provided some of the programs that I'm going to discuss with you today. We have found that it was a real benefit that the nurses that worked in those family programs with those clients, they had a strong relationship with the care coordinators that were offering maternity care services to those same clients. So it's a great partnership, it's a great network, and hopefully we will be building that together, and it will be we can be a resource for you as well. Okay, talk to you a little bit about what we're doing. Our mission at Gift of Life is since 1988, we have been building a better Montgomery, one mother, one baby, one family at a time. As Meredith mentioned earlier, we are only able to serve Montgomery County through this grant that we have. We have a disparity grant, a Title V block grant. And I want to give you some statistics a little bit later in the program to help identify why Montgomery County would qualify for such services and the other surrounding counties would not. Gift of Life has worked to lower the county's infant mortality rate. In 1988, we had community leaders come together to coordinate the development of an organized obstetrical system complete with high-risk care, much like the one that is working today in our community. Today, we operate 3 evidence-based family programs, including Growing Our Own Youth, which is a teenage empowerment and pregnancy prevention campaign. The family programs that I'm going to discuss specifically with you today are Nurse Family Partnership, Parents as Teachers, and Mobile Family Coaching. These are the programs that you will be offering to your clients. These are all volunteer programs. These are some of the statistics I wanted to share with you that led the federal government to award us the grant that we have. I'll just switch to my slide.
Sorry, we have a small technical difficulty, so give us just a sec. Oh, there we go.
There we go.
We're back.
Okay. In Montgomery County, we have almost 206,000 residents here. Our median age is 34. Under 5 years, we have 7.18%. About almost 15,000 residents are under age 5 in Montgomery County. We have about 46%, almost 47% males, 53% females, and our population by race is 63% black and other, and 37% white. The other in Montgomery County is around 1%. It's not statistically strong enough to list, so they do group that together. Our primary language here is English. The family household structure with children in a single-parent homes in the black and other community is 64.8%, and in the white community it's 17.8%. These are some of the examples of why Montgomery County qualifies for such a disparity project. You can see there are great disparities between races in our community and in our county. Again, just the demographics based on race and ethnicity. Educational attainment. In Montgomery County, we have the highest dropout rate in all of our 67 counties. And we do believe that that is part of the reason for such disparities here. The income also qualified us here in Montgomery County for this project. Below $23,550 a year for a family of 4. Children in poverty in Montgomery County, we have 34% children in poverty. The national average is 22%. And although that does not seem like a huge gap, statistically speaking, it is such a huge disparity. We're one of the highest in the nation for children in poverty. Our family household structure in Montgomery County, we have about 21% unmarried females, and again, the children in single-parent homes. Our median earnings for female working full-time in Montgomery County is $31,501 a year. And you have to remember, for that average, you have your highest wage earners averaged with your lowest. So that is not a great income level for women in our community. Receipt of public assistance, subsidized lunches in Montgomery County, 73.3%, and then we have our food stamps and snack benefits at 21.6%. Those are all much above our federal averages. We have 41% that rent in Montgomery County. The mortality rates in Montgomery County, these are 2011 stats. Heart disease, cancer, stroke, accidents, diabetes, Alzheimer's, suicide, homicide, HIV. The diabetes, homicide, and HIV are higher among our black population, and then all other causes are higher among the whites. And our health insurance status in 2011, we had 14.1% with no health insurance. Socioeconomic conditions. This was another big benchmark that qualified us for this disparity grant. 57% of arrests in Montgomery County in 2010, and this is the most data that was released to the federal government. Black and other males, 57%, and black and other female, 23%. Domestic violence was the #1 cause for those arrests. And then in Montgomery County, we have about 84% of black and other students enrolled in our public schools and 16% white. So as you can see, there are some great disparities between these statistics. Live births in Montgomery County, 2010 to 2012, we had around 9,000. Our infant mortality rate in Montgomery County is 10.6%. That fluctuates year by year. We actually have had a really good year this year. We think there's some reasons for that. LARCs, which I know you're all very familiar with, that form of birth control seems to be also helping with that. This might give you an idea, too, of in Montgomery County in 2012, and that statistically is holding it's an average for now. The Medicaid deliveries in Montgomery County were around 2,000. Okay. Let's see. Birth weights. You will be working and noticing a lot of that, too. The total birth weights for low birth weights were 321 in Montgomery County, and the disparity here is great as well. For black and other moms and babies, 259 of those, 62 were white. So that is an issue that is consistently being worked on. Improvements are trying to be made in service delivery, and really just still trying to figure out why. You're probably familiar with a lot of the new research that's come out that shows that toxic stress and social determinants are actually changing DNA and have been proven so far to lead to a lot of these health disparities. Diabetes, low birth weights can actually now be attributed back to stressors in communities and generational poverty and generational stressors. Okay, so the family programs that we offer, we serve low-income Montgomery County residents. Our clients do not have to be Medicaid eligible. They can be. We do go by low income, and we consider WIC. If you have a client that qualifies for WIC, they would also qualify for our program. We use licensed and registered nurses and licensed social workers who form special bonds with their mothers and babies, and in most cases with the families that they serve. In our family program, we have nurse home visitors, and our family coaches explore the health of the mother and baby physically, mentally, and emotionally. And they also work with clients to envision their futures and to develop plans to achieve those dreams. One large component of what they do is they work with the moms to set their goals. What are their goals? What are their needs? And then work to form plans and help them process through those programs. In Montgomery, since 2008, we have had a program called Nurse Family Partnership. It is a nationally recognized program, and it is what is coined as the gold standard in family coaching programs. Our nurse home visitors work with clients to set goals for their physical, emotional, and economic well-being. This program accepts only first-time mothers who meet with their coaches every 2 weeks in their home or another location, and each nurse home visitor serves up to 25 clients at a time. So it's a very small caseload, which allows our nurses to work with those families a lot. I did fail to mention that we do serve our pregnant women through the child's second birthday. So these are really long-lasting commitments from the nurse or from the family coach, and also from that family, from that client. Nurse Family Partnership, it's a maternal and early childhood health program. It fosters long-term success for first-time mothers and their babies in society. The studies that have been done and the research that's been done and gathered from Nurse Family Partnership has shown to reduce crime in communities. This is a program that's been around for over 30 years in other areas. We're the first in the state, and we've also helped launch a program in Birmingham. So really good statistics and incredible outcomes. So in Montgomery, because we've had this project since 2008, we do have some of our own statistics. 32% of women entered employed. 77 are employed when they graduate from Nurse Family Partnership. Over 40% of second births in Alabama are unplanned. Only 14% of our clients have had an unplanned second pregnancy at 2 years postpartum. The babies in NFP, Nurse Family Partnership, are developmentally assessed on a regular basis, and of over 300 babies, only 6 have had any type of developmental delays, and they were referred promptly. Just a little success story that we like to share. Marnechea is one of our clients, and she came into the program and she said, I just want to do this. I want to be the best mom that I can be. She enrolled in the program while she was pregnant and received visits every other week. When Kamani was born, weekly visits began for about 6 weeks. Her nurse was Nurse Kathy, and she came every Monday for 6 weeks to provide education, assistance with goal setting, and lots of encouragement. Her visits continued for 2 years of that child's life. During those 2 years, many things happened for Marnechea, one of those being that she was able to move into an apartment of her own. The baby met all of his milestones developmentally and emotionally. Marnechea learned to set life goals and take steps to meet them. Asked her a few things about how she felt in her own words, and she talked about how her relationship grew with her nurse. Her nurse encouraged her to think about developing a plan for having another baby, and she decided to wait at least 5 years to focus on her other life goals. She came up with a plan that worked for her. She is now working full-time and is enrolled in business school. And she says, I now have a plan and am sticking with it. I don't think that would have happened if she had not encouraged me to think and plan for my family's future. The thing I like the best is that Nurse Kathy has helped me as a mother. She taught me that Kamani is a baby with his own personal space, and if I crowd him, it makes him anxious and fussy. She taught me to pay attention to his actions so that I can respond in the best way. I wanted Kamani to be smart. She's learned that reading and talking to him was very important for brain development. It must have worked because he was talking in sentences when he was 21 months old. So what she's explaining is that when the nurse comes and informing those relationships, they do the curriculum I'm going to talk to you about in a moment is evidence-based. It's a parenting enrichment program. It shows and helps our clients understand and appreciate the differences, the milestones, acceptable behaviors. I can't tell you the times when I've worked in clinics when babies and small children would be in the clinic sitting there for hours at the time sometimes, and as parents, the parent would expect them to sit perfectly still and behave, quote unquote. However, that's virtually impossible for a 2-year-old to do. So in working in these programs, moms realize and they learn that what is appropriate and how to work, how to enrich their lives, how to stimulate, and those type things. She went.
Oh, no, keep going.
Okay. She went on to say that even though I canceled visits, because over 2, sometimes 3 years, it's a really long commitment, Nurse Kathy always came back with a smile. She never gave up on me.
And this is one of the reasons why I'm so excited that we're partnering on this, because this program is just absolutely fantastic. I know that when I had my son, I have a degree in human development and family studies, but when little Tyler came, all of that knowledge just flies out the window. And they have an opportunity for a nurse to come into the home. There were so many times I had questions about, oh my gosh, what's he doing? And I would call my mom, I would call my mother-in-law, and I just think it's great that they have this resource that they can have a nurse physically coming into the house and helping them. And I nursed for quite some time, and I remember being on the phone with the La Leche people, the breastfeeding consultant, for hours because he wasn't doing something right. He wasn't sleeping right. There were just so many different issues that it would have been so fantastic to have had somebody physically come into the house and see what it was that I was doing, because you have so many questions, especially as a first-time mom. You can be as educated as anything, but when that little baby comes and they aren't sleeping at night, and there's so many questions that you have, that I just think this program is fantastic, that, hey, there's this nurse is going to come into the house, they're going to give me their undivided attention, and I can ask questions and not be judged or questioned, like, why don't you know that?
Right.
So I just think it's just so fantastic that this opportunity is out there for them.
And it really does. It actually, I'll talk to you towards the end about a graduation ceremony that we do, and there are tears, and I'm not going to see you again. It's been 3 years that you've been such a great support system for me. So it really does. Another benefit to this and our other programs that we offer, I think we all know that when you have generations living in homes at times, we have old information, just like the safe sleeping that you're going to talk about, and breastfeeding, those type things. The information we know today isn't necessarily what was taught and what was appropriate and considered safe 10 years ago, 20 years ago, 40 years ago. So sometimes, although your client, your patient, is learning these new ways of sleeping, for instance, grandmother has another idea. So it's just helpful when there is that other voice coming in and working with the family and kind of bringing everyone up to better health goals and safety information.
Yeah, I remember one of the moms, I can't remember which one it was either my mom or my mother-in-law, give him water. Give him lots of water. Like, no,
right.
You can't do that.
Yeah.
No,
cereal in the bottle. So, all those good things.
All those things, yeah, they don't want you doing that anymore. So it was interesting to see how, and we all turned out just fine, but how things have changed since our moms were having us, and so they're giving us that information, and now it's different. So this nurse can come in and kind of help
keep
with
them
those
up to date.
issues.
That's right. So that was Nurse-Family Partnership. We also offer Parents as Teachers. It is also a nationally recognized program to encourage and support parents and families. Our family coaches are licensed social workers, and we do have some nurses that do that as well. They work with parents to set goals, develop strategies for parenting, and encourage emotional, social, and physical well-being for baby and family. Our family coaches meet with their clients in their homes or another location of their choice every 2 weeks during the program. Clients may already have a child with Parents as Teachers, and they may enroll up to their child's first birthday. So this program is a little bit different, and we offer this one because, if you remember, Nurse-Family Partnership is only for first-time moms. So this program allows us to have clients that have already had a child and they may, that latest birth, that child can be up to 1 and we can enroll them. And these family coaches also have up to 25 clients for each full-time family coach. The concept for parents as teachers was developed in the 1970s when a Missouri educator noted that children were beginning kindergarten with varying levels of school readiness, saying children weren't ready for kindergarten. Research showed that greater parent involvement is a critical link in the child's development of learning skills, including reading and writing. Our family coaches help parents develop strategies for securing the social, emotional, and physical development of their children. With these programs, there is this evidence-based curriculum that we do, but because we are licensed social workers and nurses, we also do a huge case management component as well. So not only are they doing the Parents as Teachers educational parenting curriculum, they're also doing the psychosocial assessments, the ASQ, PHQ-9, all of those screenings, life skills planning, all of those screenings that we do as well. Here's a Parents as Teachers success story, Tontiyana. She was in the 9th grade when she learned about her pregnancy. Marnechea, her daughter, was born in August, just a week before school was ready to start back. At 16, Tontiyana was afraid of leaving her baby in commercial daycare, so she was not going to return to school. In October, she went back to work, and she decided that fast food service would not be her long-term career goal, and began to think about going back to school. Marnechea has exceeded all of her developmental milestones thus far. She is responsive, calm, and she smiles easily. She's a happy baby. Her parents have developed a relationship, so now she gets to spend time with both her mother and her paternal grandparents. So what happened was Tontiyana was not going to go back to school, which we see so many times, hence our graduation rate. Sometimes we have a lot of pregnant teens in the school system that don't get homebound services and things like that because of the protocols that are set up in our school system. She wanted to go back to school. She started Parents as Teachers program. Her family coach worked with her to set those goals, what needs to be put in place in order for her to achieve those goals. And so they worked on those together, and they are on a real positive plan at this time. Mobile family coaching. This is a new program that we are actually developing as we speak. We offer clients a flexible approach to family coaching. We're using the proven curriculum, Parents as Teachers. They work with our clients using technology from phone calls, text messages, FaceTime chats, and in-person meetings. So mobile family coaching is a combination using an evidence-based protocol such as Parents as Teachers, but actually having the client be able to have some more flexibility in how we work with her. It is proven so far, we've been doing this for over a year, and statistically, we're actually in line with Nurse Family Partnership and Parents as Teachers as far as retention, outcomes so far, breastfeeding, smoking cessation, and those life goals that our clients are setting. So we're very excited about this. We have students, college students, working. We have a teacher in this program right now. So we're really, really excited to offer this mechanism. Someone can receive this support and these services. Family coaches work with clients to develop parenting strategies, set goals, establish habits that encourage a healthy lifestyle for mother and baby. And they also may enroll clients up until the child's first birthday, and they may also have more than one child. So again, a little bit different than the Nurse Family Partnership requirements. Our family coaches meet in person with their clients at the location of their choice every 10 weeks. So we do have some face-to-face contact as well as that first initial. Additional visits take place remotely by phone or other technology. And because there aren't as many face-to-face contacts, they are able to serve up to 50 clients for each full-time family coach. Camellia is one of our great success stories that we're thrilled about with mobile family coaching. She was enrolled and excited to be welcoming a second baby. Camellia is actually employed she says it's not full-time, but it really does seem full-time. She's a pharmacy tech, and she works a lot. She was hospitalized at 18 weeks pregnant and spent her days cooperating in any way she could to stop the labor that would lead to a too early birth. Sharon was her family coach, and she kept in close contact with Camilla through text, phone calls, cards, anything to encourage her as the days grew long. Just a little background. Camilla was not receiving support from her family. Again, just lack of information, lack of understanding. Her family did not agree with the doctor and did not believe that she needed to stay in the bed, be in the hospital, those type things. And was really encouraging her to just get up, go about your life, you're going to be fine. So she had that support from her family coach, do what your doctor suggests, you can do this, we're going to be here for you. Her son, Adrian, was born at 26 weeks pregnant. 7 months later, he is still in the hospital. He's at UAB. He is well loved. Whenever there is a day off, his family visits, often rooming in so that they can hear her familiar voice, feel the strength of his dad's arm, and learn to recognize the giggles of his big sister. And I will say that Camilla is still nursing. She's still pumping breast milk that she delivers to UAB. She's that committed.
That's great.
I know. Christmas was celebrated in the hospital together as a family. She actually goes up almost every Thursday and stays. She has had to make arrangements with her daughter with a family member because her daughter can't always make that trip, but she religiously goes and visits her baby. And there's she's giving the gift of mother's milk to the baby. In the father's words, he said, "You hardly knew us, yet you made sure we had food when we were focused on just getting gas to make the trip to UAB." That goes back to that relationship. Although they just needed, some gas money to get up there because, like I said, she does faithfully go every week. Their family coach knew, when you're up there, how are you eating? How is this working? We know the price of gas. We know how expensive if you've ever had anyone in your family have an extended hospital stay, it's very draining. Emotionally, you're tired. Income is a consideration for this family. Even when it's not, it's a very financially draining commitment. So they just recognized that having that support made a difference in that way as well. Okay, those are our 3 family programs that we offer. We also offer some support and enrichment services. We have breastfeeding support, counseling services, group connections. We have a community action network, community involvement, and a graduation ceremony. Our breastfeeding support, we have a certified lactation counselor. She's available to the nurses and family coaches for consultation. She provides visits to clients who are experiencing problems, and if there are problems that she cannot, if they're seem too large, she refers them straight to the IBCLC that are hired, employed by the hospitals in our area. So this is a great support system, and as you can imagine, it is used very frequently because breastfeeding is one of the activities that we do strongly encourage, and we want to provide our clients with all of the support that we can do. So we really do pull and utilize our lactation counselor.
And what is the IBCLC?
Those are actually lactation consultants. That's another level of certification, and they are housed at your hospitals. Baptist East, Baptist South, Jackson, they all have an IBCLC.
So that's the person that came into the hospital room while you were still there right after delivery.
Right. Okay. She's certified as a higher level. That is her full-time job.
Okay.
And we do have great relationships with those at the hospital, and they will work with us, give our counselors some suggestions, that type thing. So it's a great partnership, and it's a real benefit for our families, our moms and babies. Counseling services. This is something that I am so excited about that we're able to provide. When we do our screenings and they show that there are some mental health services that are needed, you probably experience that those can be few and far between sometimes in our community, and for whatever reason we have clients sometimes that don't want to assess community mental health. we are able to provide counseling sessions at no cost to our client. So we have an arrangement with an LPC in town that we actually, if they score a certain level on a PHQ-9, an anxiety and then a depression screening, we're able to automatically make that referral. However, if we do have a client that we recognize or they state that they are experiencing some depression or just some things they're concerned about, we actually can make that referral and make that connection. We do initially just pay for 4 right off the bat. If the patient requests more and the counselor requests more, we also do that. So this is something that I know as social workers out there, you really see a need. So I am so excited that we're able to do this. And it really is making a difference, we feel. Group connections. Actually have this meeting at the health department on 2nd floor bi-monthly. These are bi-monthly meetings where we bring our families together to build social connections. They engage in parent-child interaction. They do some fun, neat things, and at the same time, they gain some knowledge and ways to support their child's development. This is such an important piece, I feel, because what we are hoping happens is that our clients build connections with other people in their community. Because we know in 2 years, or 3 years sometimes, at the child's 2nd birthday, we're going to walk away. And we want that client to have a support system that's strengthened or one that's there that maybe wasn't there before. So we really encourage and foster those connections with other moms in their community. We also have a community action network. We work right now with the Healthy Minds Network, Envision 2020, which you may be familiar with if you may have seen some things on the news about that over the past 10 years, really. Quality mental health care for all. Recovery, treatment, and prevention is actually the goal for that. So it's really nice that we're able to connect them with that and work in a collaborative effort to try to improve those mental health services in our area. We have our family programs graduation that I mentioned. This year, 2016 in May, we had 34 graduates. So these are clients that have completed 2 to 3 years of the program. Their child is 2 years old this year. Nurse Family Partnership, we had 19 graduate. We had 3 mobile family coaches and 2 parents as teachers. The numbers are lower on those 2 newer programs because they are newer. We have not been doing those programs for 2 years. But hopefully next year it will grow and the next year it will grow. These are just some involvement and affiliations that we have in the community. There's a lot. It's important just to be involved in all of these different things because we reach out a lot and we need them and hope to build partnerships. Okay, referral form. So I wanted to share just a little history and background about what we are doing because what we would love to do with you is to receive referrals from you. The great thing is that you don't have to determine which program the client would fit into. We do that based on things like gestation, first-time mom. Does the client want home visits? Does the client want to do mobile family coaching? Sometimes clients want our services, but they don't necessarily want us in their home. That can be because they live with someone else and that might not be comfortable or just for whatever the reason is. So you don't have to make that determination. What we would love for you to do is just talk and share about our programs and make this and offer these programs to them. We'll go over the referral form and then I know it's small on your screen. But if you could fax that in, we also have a link on our website that can be made online. That would be great. We then contact the client, set up that initial, and begin services. Do they have this where do you want me to go through it?
It's on the on-demand page, but yes, you are welcome to walk them through that and any help.
We'll just briefly look at this then. Okay, so the referral form, it's got our fax number at the top. You could fax that, or again, you can email a referral, scan and email it, or access our website. You can Google Gift of Life Foundation and just find the right one. You'll have all the blood banks and different things like that come up, but you'll recognize Gift of Life. just the day, the agency or the practice, and that would be Montgomery County Health Department. Your name and your phone number. And just it gives a brief overview of the type of case management that provides support, education, and encouragement beginning in pregnancy and continuing until the child reaches age 2. And then the goals of family coaching are to help a family have a healthy baby, be the best parent or parents possible, increase in family self-sufficiency. We would like to have her name, her date of birth, good contact numbers, the best time to call if there is one, the address, city, state, zip. And as Meredith mentioned, we are just Montgomery County. May Gift of Life speak to a family member, yes or no, leave a message, yes or no, and then their preferred method of communication, an email address if they have that, and then if they would sign the form, and then date that, and then if you could just zip that over to us, we will immediately. We have a protocol where as soon as we receive the referral, we're making that contact at least by the next business day. So
now we have a system called Falcon where they have their demographic information prints out on a little label on a sticker.
Yeah.
Would it be okay if they just took that sticker and just stuck it on the form right there?
That would be great.
Little time saver there for you. So you can just take your Falcon label and pop it on that form so you don't have to fill that out completely. And we would like to see your Montgomery County residents. We would like to see the majority of them referred. I would love for all of them to be referred, but I don't live in a happy world sometimes. Yeah. So I know that some of them are going to decline services, but if you could encourage them to be referred to these programs, they just offer such wonderful support and education to the patient. So.
Right, and I appreciate you saying that because we would love for all of them to be referred to us. But there are some that are hesitant or no. And when I encounter clients, I go to COPE every Tuesday morning and talk to clients there for parenting classes about our programs. And initially, if they say no, what I have found, it's really in the approach. And the truth is, what are the services? What can we do for you? What can we offer for you? And just talk about the outcomes and just the support, enrichment that they receive. And the majority of the time, that's the turning point. And I've heard clients say, who would say no to someone coming to help me? And I completely agree with that. So I'm always happy when I hear that. So this is a referral form. But yes, absolutely use the label, whatever keeps it the simplest for you. I know how having 20 forms for one thing, how that can be. So we want to keep it the simplest that we can for you. So this is a referral form. Any questions about that? Call Meredith, and we'll work that out. Okay, just a great quote that I love from Mother Teresa. It kind of sums up what you do every day, what we're trying to do. Spread love wherever you go. Let no one ever come to you without leaving happier. And then that's our website down at the bottom.
Well, Paige, thank you again so much for going over those programs. I just think they're going to be excellent. So, and I've told Paige I would absolutely love to steal them all and replicate them statewide. But she and I talked a little bit yesterday, and there are reasons why we can't do that because of the disparity issues that you have to meet certain criteria for it. So that's why it's only in Montgomery County. And the great thing is that for those Montgomery County workers, you don't have to figure out what they're eligible for. The Gift of Life is going to handle that for you. You just have to get the form over to them, and then they'll determine which program the patient needs to be in so that you won't have to struggle with that decision. We're going to move into now more of the reporting part of the program, where I'm going to go over for you your report to referring provider for your documentation piece. So if you would like to print out that report to referring provider and have it as I'm going through that, that would be great. Again, I want to remind you to please call or email us. We're sitting right here. We are happy to take questions. So if you have any questions, please don't hesitate to call or email us. So I'm going to jump back in. We're going to start with the postpartum appointment. It's very important for the patient to keep that postpartum appointment. The patient needs to be checked to ensure things are healing properly and to become established on a reliable birth control method. just because the patient feels better doesn't mean that everything has healed properly on the inside. So sometimes it takes a little bit longer for that internal healing to happen. So encourage the patient to keep that appointment to make sure that things are healing properly. Birth control. You want to begin discussing birth control options with the patient as early as possible and encourage a reliable method. You want to provide education on various birth control options and let the patient know that a long-acting reversible contraceptive, a LARC, is the most effective and can be placed while still in the hospital for delivery. Before Annie left, she had been on some webinars and some things, and there's some research out now about LARCs. And what they were finding was that the name was a concern for the patient. They were like, I don't need anything long-acting. That, for some reason, the way it's termed right now, the patients aren't latching onto it as much as they'd hoped. So one thing that we're trying to do is to encourage it as a low-maintenance possibility for the patient. So it's more of a low maintenance type option for the patient. And when studies were done, it showed that when it was termed a low maintenance option, that patients were more likely to latch on and to use that type of method. So it is still a LARC, but if you want to remind them, hey, this is a low maintenance type method, you get that IUD placed and you're done. You don't have to worry about it anymore. And especially when they're in the hospital for delivery, I mean, they're already in that area quite a bit, so they can go ahead and have that IUD placed while they're there, and then it's done, and they don't have to worry about their birth control for several years at that point. So that long-acting reversible contraceptive is definitely a good option for a lot of patients, and it's one that we want to try to encourage because it is so much more effective and reliable. The patient doesn't have to remember to pop a pill every day. They don't have to switch out a patch. They don't have to come in every 3 months for a shot because we love shots so much. So this is an option that's it's something that can be done quickly and be done with. So if you need more information about that, we've got plenty of brochures and educational information on the LARCs that you can have in your office to try and talk with the patient about. We also are going to ask that you're trying to encourage the patient to establish a primary medical provider for the infant. We want to ensure that that patient has a PMP lined up for the infant upon delivery. Let them know that that PMP is going to come into the hospital while they're there with the baby. So after delivery, follow up with the patient to ensure the infant has been established with the PMP, meaning the infant has been taken to a PMP. I remember when Tyler came, I can't remember what day I was discharged on, but I was actually in the PMP's office on Sunday. So I think I went home on like a Friday, and I was back in the PMP's office on Sunday with him. So they sometimes have to go in 1 or 2 days after discharge from the hospital, and then we were going every week there for quite some time. So they may be going to the PMP quite often right after the baby comes. So make sure that they're following up and keeping all of those PMP appointments for the baby. And encourage the patient to keep all of them. We want to make sure that they're keeping those appointments with that primary medical provider, because they're getting those immunizations done. I know they get some at 1 month, 3 months, and the poor little guy's a pincushion there by the time we keep going to the PMP. But we've got to encourage the patient to take the baby in for those appointments. So let's talk about the fun part, which is our documentation piece, the report to referring provider. Now, the ACORN updates are going to take quite some time to get completed. We are doing quite a bit of programming with this form, so it's going to take a while for all of those updates to be live. What we have requested is for things to come out in drips and drabs for you, meaning I've asked for the referral form to be updated first so that you can complete a referral form where you're going to mark that self-family. That's not a change, but the maternity case management piece on the reason for referral tab, that's got to be added. So as soon as that's added, we might be able to release that to you. Coding's kind of important. So the coding changes, I think, are next up on the docket to get put into ACORN. So as soon as the coding is available, we will send that out to you. So I know the next question is, well, where do we code? if it's not live yet. You can code to patient first right now because these patients are eligible for patient first. I would love for you to be able to go back and change the coding later, but I'm not going to require you to do that. So as long as you're coding it to 21 and 31, it's going to get picked up and billed to Medicaid, which is fine. And then as soon as the codes are released, we can either change them or you can just start from that point. We will provide you with further guidance as to what to do regarding the coding once we know when it's live. The next, the case plan is still being updated as well. I think that will be the next piece that comes online, which means the report to referring provider is going to be last. So we've come up with a kind of a solution until it's ready to go. We've created a Word document template, which is going to be a point and click kind of form. So, and it's just a bunch of questions. And again, it's on the on-demand page. It's also on the document library. So feel free to print that out and take a look at it. You are welcome to fill this out however you would like to. If you want to print it and do it by hand, I have no problem with that. You can also save it to your computer and you can actually point and click on it all the way down and complete the form that way. Since it is point and click, I'm hoping it's not going to be too time consuming to work through that form. It started out at 3.5 pages. It's now pretty much 4 pages long. And any place that you see on the form where it says click here to enter a date, when you hover over that, a calendar box is going to pop up so you can select a date. If you select an answer and it needs to be changed, then you have to click on the incorrect answer to deselect it and then click on the correct answer as well. I have noticed the form is a little bit temperamental. We had to go in and add some text boxes. Those were a real challenge to make work every time, and I figured out a little trick to the text boxes. What you do is you only click once. If you double click, you're not going to be able to type. And when you click on it, you want to click as far to the left of the text box as you can, and then you're going to be able to type. So those text boxes are temperamental. I'm not sure how to make them a little bit easier to work. If you have any suggestions, I would love to hear them. So if they're frustrating you too much, then just go ahead and print the form out so you can just write on it. This is just a small example of the form. You'll see when was the first prenatal appointment, and it says click here to enter a date. When you hover over that, you're going to get a calendar box that pops up, so you can just select the date of that first prenatal appointment. How many weeks was the patient at first prenatal appointment? It says choose an item. When you hover over that, you get a list of like 0 to like 43. So you would select how many weeks the patient was when that first prenatal appointment occurred. Did the patient have to wait to see a doctor because Medicaid was not yet active? Again, it's a yes and a no, so you just click on whichever one is correct and it populates a little X in there for you. So I'm hoping it's not too hard to work with, but again, it can be a bit temperamental, so if it's frustrating you, just print it out and you can handwrite it. That's not going to be a problem. Most of the questions are pretty self-explanatory, like did they have Medicaid when they went to the doctor the first time? But if you're unsure of what a question means, please do not hesitate to call or email me. I am more than happy to answer questions about the form. The reason we're asking certain questions is for data purposes for multiple programs. As I mentioned earlier, I told you that the perinatal program nurse is going to get access to Acorn so she can look at your psychosocial assessment. She's going to be pulling information off your psychosocial assessment. We're pulling data for perinatal off of this report to referring provider as well. The RCOs are looking for certain information, and this is a fantastic opportunity for us to prove to them, look what we can do. So in the beginning of it, we can show, hey, it's taken, 10 weeks to get on Medicaid. Well, hopefully, through this process, we can work with the patient and talk to people at Medicaid and try to get patients on Medicaid quicker. So if we can show how valuable our services are, then it's a better opportunity for us to be able to contract with the RCOs when they do actually stand up. And again, we don't have a date on that yet. So as soon as we know something about that, we're going to let you know. But So we're tracking a lot of data off of this form, and we're also looking at this for a return on investment. I don't have the exact statistics in front of me, but it's something around like $54,000 a day in a NICU. So if we can educate on those early elective deliveries and keep a patient out of a NICU, one baby out of a NICU can save an RCO $54,000. So if we do that just one time, we have more than paid for our services. So the maternity piece is an excellent opportunity for us to try to prove our worth and show our return on investment to the RCOs. So if you have any questions, please don't hesitate to let me know, because we want to make this as effective as possible. There is a question on the form that, if you've never worked in maternity, it's a mystery. It's, what does that mean? It's gravida and para. Gravida refers to the number of times a patient has been pregnant. This will include all pregnancies, no matter the outcome. If you're working a maternity case, automatically you know that it's a gravida 1, because that patient is pregnant. So if the patient's pregnant, she's at least a gravida 1. What does para mean? Well, that's the number of births the patient has delivered that reached at least 20 weeks gestation. Births and miscarriages prior to 20 weeks gestation are not included in the para number. So a couple of examples, because this can be confusing. A patient is currently pregnant, so I know she's 1, and she has a 2-year-old child. So I know she's been pregnant twice. So she's gravida 2, and she has a 2-year-old child, so she's para 1. So she's a gravida 2, para 1. A patient is currently pregnant, has a 5-year-old child, and had a miscarriage at 10 weeks gestation. She has been pregnant 3 times, but has only had 1 pregnancy that lasted past 20 weeks. So she's a gravida 3, para 1. You've got a patient that's currently pregnant and has a set of 3-year-old twins. She's actually a gravida 2, para 2, because she's got 2 children that came. So if you have questions about that, please don't hesitate to call or email me, and I'm happy to walk you through that. So a little bit more information about this report to referring provider template. It's a working document and should be completed throughout the pregnancy as information becomes available. There's a question on there that asks you when the prenatal appointments occurred. So there's a big block of choose the date. So that kind of tells me right off the bat, I'm not going to be able to complete this and send it in after one time with the patient. No, you're going to document every single time the patient keeps a prenatal appointment. So it's going to be on that form. So it's kind of a working document that you're just going to keep working through with the patient. We're going to have an intern here at the central office that's going to be responsible for entering the forms into Acorn once all the updates are available. You are not going to be responsible for going back in and entering that data into Acorn. We're going to have someone here in the central office go into each one of your records and input that report to referring provider once the edits are there. And again, we're going to keep you posted and let you know when that occurs. You do not submit the form until the template is complete. So the case should be closed when you go to submit the template to us. They can be sent to the central office in whichever manner is easiest for you. I have no preference on how these come into the central office. They can be sent via hand mail. If you do that, please make sure you make a copy first. We would hate for them to get lost in the hand mail process, so make a copy if you're sending me your actual form. You're welcome to fax that into us. You can also scan it in and email it. Not a problem. Whatever is easiest for you is going to work for me. Because where are they going? They're coming to me. So you can just send the templates into my attention. You can send them to my email. You can send them to our right fax. You can put them in hand mail to my name. Not a problem. We wanted to make this as easy as possible for you because, oh my goodness, at the things you have flying at you. So just send them to me. We will handle getting them distributed. We will handle getting them entered. The actual report to referring provider is going to be very similar to the template. The questions are the same, but it's going to generate certain questions based on previous answers. It's kind of similar to your smoking cessation tabs in Plan First. My example that's coming to mind is about the gestational diabetes. So like in ACORN, when it asks, was the patient diagnosed with gestational diabetes? Yes, no. If yes is selected, then ACORN is going to generate those questions about the classes. But if no is selected, then those questions won't generate. Well, the Word document wouldn't allow us to generate questions. So all of the questions are listed on there. If the question is non-applicable, you can just leave it blank or write NA beside it or type NA out to, you won't be able to type on it, so you would have to write NA or just not answer that question. But it would have to make sense. So if the patient was diagnosed with gestational diabetes, I would expect the questions about the classes to then be answered. Again, if you have questions, please do not hesitate to call or email me. But it should be kind of like your smoking cessation form where the questions generate based on what the previous answer was. So I have gone through the form and kind of gone through what's going to be required in protocol. Please do not hesitate to call or email us. We've got plenty of time left on the broadcast right now, so this is your opportunity to talk to us live if you have any questions or concerns. And once you're watching this on demand, if you do have questions or once you start working the program, always keep your supervisor in the loop as to what your questions are, because it could be that another care coordinator has the same question. So then if your supervisor knows what's going on, she can help educate your coworkers about that as well. So we've got several more minutes. If you have questions, you are welcome to call or email us. Paige is still here too. So if you have a gift of life question, she's happy to take that as well. I know that there's not everybody's watching live today, so anything? No? No email. No email? Well, Paige, thank you again so much for coming today. We really appreciate having you, and I think that the Gift of Life family programs are going to be just wonderful.
Thank you. Thank you for giving me an opportunity to share our programs with you.
Oh, we do have a phone call. It is from Montgomery County. So Montgomery County, go ahead with your call, please.
I have a question about the template. So help me understand. Since it's a working document and the workers are constantly adding information to the document,
yes,
will there be several documents? And like you said, once they close the case, that's when they can submit it. So I guess I'm trying to figure out, like, if we have multiple risk assessments, and when you go in and kind of edit a risk assessment in ACORN, it'll show you, well, it was edited this date, and you have the original. Is it going to be kind of like that, or help me understand? Every time they enter information, they're saving it. And
sure, not a problem. The working document piece to this puzzle is more necessary, I think, for the Word template. So let's talk about that, and then I'll address it once it gets into ACORN. So when it's on the Word template, I would just think that the worker would go in and save the document with the patient's name. Or if they want to print it out and do it by hand, they could drop it in a file in their desk. And just as they keep those prenatal appointments, go in and document on there when that prenatal appointment was and just keep saving it. So that by the time the patient delivers and we've completed that postpartum appointment and the infant's been to the PNP and we have all that information, we would save it and you could then email it to me or fax it. Or if you're doing it hard copy, just complete all the information, make a copy, and send it in. So when it's the Word document, I don't see them having multiple copies on the same patient. I would just think they would save it under the patient's name and just continue to edit that same document.
Oh, okay.
Okay? Now, I want to talk to you about ACORN. When it goes into ACORN, you just wouldn't click send on it. And thank you for bringing that up. I did not address that. These are going to drop into a spreadsheet. So when you click send on the report to referring provider once it's live in ACORN, it's not going to go anywhere. It's just going to drop into a spreadsheet. So each time that they save it, more data is going to drop to that spreadsheet. So they can just keep going into that same form and continue to edit it. They will not create a new report to referring provider each time they keep a prenatal appointment, they'll just go into that same one and continue to edit it. And then once they're done, then they would click send and it would shoot over to that spreadsheet. Does that help?
Yes, and let me ask this. Once they click done, you said that you still want them to send that in to you.
Now, when it's on the template, when it goes into Acorn, they're not going to have to send it anywhere. It's going to happen electronically.
Gotcha.
Yes, ma'am. So when it's the Word template, it's just going to be faxed, emailed, or dropped into hand mail to me. But once it goes live in Acorn, they won't use the Word document anymore. It will go away. They won't need it because they can just go in and do that in Acorn.
So when are we starting?
You can, you're good to go. You've got training now, so you can start seeing patients when you want to.
Okay. And my last question, with the Gift of Life referral form, and I know we're probably going to be just referring like crazy, but as long as the bottom of that CHR6 is signed, we can just refer. There's no other questions we have to ask the patient. Is that correct?
I would get the top signed because you're actually going to be sending out written information. So
we're doing both.
I would sign the top of the form because you're going to be giving them it's going to be written. Okay. And the other piece to this is the client's actually signing this referral form that you're sending to the Gift of Life too. So, yeah, the client has to sign the Gift of Life referral form.
Now, client signature.
Yes, but I would still have them sign the top of that CHR6A. That's just covering all our bases.
So they're signing the 6 and this form.
Yes, ma'am. They've got to have, the Gift of Life has to see that the patient was okay with them sending that. So the signature on the referral form for Gift of Life is for their purposes so that they know the patient has consented.
Okay.
But we'll want the CHR6A done as well.
Okay. And as far as our referrals, getting the folks. First of all, let me just say we got on late because we were trying to watch it in classroom too, and we couldn't, and so we had to run back to our desktops.
Okay.
Did I miss how we're going to get our folks?
I anticipate they're going to come to you through the WIC clinic. So as a patient comes in for WIC when they're pregnant, you would want to go and talk to your WIC staff and let them know, hey, when you have a pregnant patient, you can now route them to me. You are welcome to go out and market to the private providers in your area, but it's not required or expected. I'm thinking that once you're going to be calling that private provider to find out about their appointments, I'm thinking that once they realize you're doing this, they're going to start sending you patients.
And we can also direct them to call the county health department because patients still call us and want to know, I need an appointment with the doctor because that's been history for 18 years now. So we will definitely say I'll get with you and make sure that I have the right numbers for them to call. So
I'll make sure I get Paige the list of all of the county health departments for the 8 Gift of Life counties so that she'll have direct numbers to those county health departments. I can also tell her who your social workers are so that then she can give the patient calling an actual name in that county. And then so Gift of Life's going to be helping us do that as well. Does that help?
It does help, and I guess it seems like we're going to be partnering a lot with WIC. So are our WIC folks from the central office and our local WIC folks, are they on board, or is that just something locally?
I can tell you that Amanda Martin knows because I went and talked to her when I was developing the protocol and the report to referring provider, and that's how I made sure that the WIC 157 form was put into this presentation and is on the on-demand page and on the document library. So Amanda knows, but I will go back and touch base with her and find out, do we need to send something out to the WIC staff so that they're aware? And thank you for reminding me to do that, Kimberly. And we'll coordinate something from up here as well to try and communicate that out better.
Okay, I think I'm up to speed now. Thank you so much.
You're welcome.
Bye-bye.
And thanks. We've got, no more at this time. Okay, but I think we have an email. Oh, no, you just had a question.
I have a question.
Sorry, Melissa has a question.
I'm the care coordinator, and I complete the template. Would I then document that in Acorn that I updated the information, and then so I'm wondering, would a copy need to be made for the hard copy of the record for the health department?
Melissa does an excellent job of making sure that I get all of my I's dotted and T's crossed. Yes, if you do anything to that report to referring provider template, the Word document, you'll also want to document in your progress note that you've updated that report, and then you'll also want to make a copy of the template once you're done with it and put in that CHR in the record so that that is in the record as well. So anytime you do anything, you'll want to document that in the progress note, because again, we're billing this to Medicaid, which means we're going to have an SSR, which means we're going to have backup documentation for that.
And my second question, with the changes with Medicaid and patients now having, maternity patients having full Medicaid benefits, is there a need for our staff to encourage the use of dental providers in trying to help assign?
Again, Melissa does a great job of making sure I hit all of my bases. If you've got a patient that is under the age of 21, she is on full Medicaid, which means she actually has dental benefits right now. So you'll want to encourage her to keep her dental appointment, to go to a dental appointment. You'll also want to encourage her to have an EPSDT screening so that she can go ahead and have that done as well if she doesn't have one on file. If the patient is getting ready to turn 21 and that eligibility code is going to change for Medicaid, please encourage her to have that dental appointment. Once she turns 21, she no longer has dental benefits under Medicaid. So this is kind of an opportunity to pick up those younger patients and try to get them some dental care before they age out of Medicaid. So good point. Good job. Okay. Do we have any other questions? Okay. Well, Paige, thank you again very much for coming. This was very informative, and I appreciate your time and your energy to come and put this on.
Oh, thank you for giving us this opportunity.
So we're super excited. But when you start seeing patients, if you have questions, concerns, or issues, please do not hesitate to call or email me at any time. Oh, we've got another call. We're getting it patched through. It looks like it's coming from Montgomery. So, caller from Montgomery, go ahead.
I just wanted to know, initially, we would see the patient face-to-face that first time. What if the patient comes back maybe a week or two later and she wants to talk to you again? Would it be a limit on how many times we can do a face-to-face with them? Or, I mean, there's no limit because you know how some patients may come back and this is going on and that's going on. Is there a limit on the contact?
No, ma'am. You can see the patient as many times as necessary. And if they are in the health department, feel free to see them face-to-face to touch base with them. That is fine. Not a problem at all. And you'll code your time to the patient. Okay.
Thanks.
Okay, thank you. We've got a call from Butler County. So go ahead, Butler County. I'm having a hard time hearing you. All I'm hearing is static. Oh. I still can't hear you, Butler County.
Yes.
There you go.
I couldn't hear you either.
Okay.
Yes. My question is, you were saying once a patient reaches the age of 21, they can't... Okay. Do you hear me now?
I can hear you, yes, ma'am. You said something about once they reach the age of 21. I'm thinking you're about to ask me about dental, but I could be
Yes,
wrong.
I was about to ask you about the age of a patient, because normally once a person turns 19, they lose their full Medicaid benefits. You're saying now that they can go to the dentist?
There is a bit of a question on the 19 to 21-year-olds, so let us follow back up and just double-check that for you. I don't want to tell you something that is incorrect. Medicaid status actually for children goes up to the age of 21 according to patient-first eligibility, but we will, Melissa is dutifully writing it down right now. So we will double check that because I don't want to tell you something that's incorrect, just to make sure, because yes, I have heard the same things about 19 as well. So
I think I double checked that when I
Okay.
put it on the template
okay,
when we made the change there, but I'll double check it.
we're going to triple check it because I think we had the same question when it was put on the template initially, but we'll triple check that just to make sure, and we'll send something out, and that might actually be a little tidbit of information to send statewide too, not just to our these 8 counties, just a little reminder about reminding patients to get that dental appointment done before they age off and switch over to the adult Medicaid. So, okay, we will triple check that just to make sure. I don't like telling you something that's wrong. So, okay, well, we do not have any more calls at this time. Do we have any emails?
No, ma'am.
No? Okay. All right. Well, I'm going to thank Paige again. So thank you again for coming. We appreciate it. Again, once you get started, if you have questions, concerns, or issues, please do not hesitate to call or email me, and just keep your supervisor in the loop on those questions so that they know what's going on as well. Oh, see, I stretched again. We got an email in.
If I can get it. Okay, when we update the Word document, don't we need to document specifically what we updated?
That is excellent case management. So I'm on board with that 110%. If you want to put in your progress note what the update was that was made to the Word document template, or when the edits go live in Acorn, to document that in the progress note, that is excellent case management. That is a wonderful question. I'm all about best practice. Yes. You can put the specific information in the progress note as well as on the template or in Acorn once it goes live. Yes. Any other emails?
No, ma'am.
Okay. All right. Okay. Well, thank you again very much for joining us today. If, again, questions, email or call me anytime. Happy to help. So thank you again for taking on yet another new task. We think this is going to be an excellent opportunity for us to show our worth to the RCOs and to show our return on investment to the RCOs. So we want this to go great. So please, if you have questions, don't hesitate to call or email me anytime. And thank you again, and I hope you have a great rest of the day. Thank you.